Hello, everyone. My name is Peter Fiester. I'm a associate professor of neuroradiology at the University of Florida. I'm going to talk about the imaging anatomy and traumatic injury of the craniocervical junction. It's kind of a passion I have for this particular area of the body. I've done a bit of research in it as well. So I hope you guys enjoy this lecture. So topics we're going to discuss today, the idea or the concept of a craniocervical dissociation spectrum injury. And then we have to have a very good understanding of craniocervical junction anatomy before we kind of dive into the imaging findings. And then once we do that, we'll talk about the CT and MRI appearance of radiologic anatomy of the craniocervical junction. And we'll look at a few specific traumatic cases. So for those of you who are not aware, so neuroradiology really encompasses three separate fields. It's brain, spine, and head and neck. And if you did a Venn diagram and tried to place where the craniocervical junction is, it kind of overlaps with all three of these anatomic regions. And I think for that reason, sometimes the craniocervical junction gets a little bit ignored because it doesn't fit neatly into any particular subspecialty of neuroradiology. So points to remember that craniocervical and subaxial spine, so that is the craniocervical junction and the spine inferior to C2, they differ quite a bit in embryologic development and anatomy, function, biomechanics, and trauma. And the reason is that the craniocervical junction has a unique job that has to balance maximum stability with the greatest possible range of motion. And the increasing utilization and availability of cervical MRI is starting to alter our radiologic perceptions of craniocervical junction trauma. So a few quick points to remember: that trauma at the craniocervical junction, again, is a spectrum of injury severity, and it's determined by the patient's age, their bone density, their underlying ligamentous integrity, and then, of course, the severity of the traumatic forces applied to the craniocervical junction. So the concept is that as a spectrum, the most severe is that you're going to have a complete tears of all craniocervical junction ligaments that results in basically a closed capitation injury or dislocation. And then the least severe injury are just going to be isolated tears of one craniocervical junction ligament, for example, an alar ligament avulsion. Now, between these extremes, there's various patterns of trauma you can get at the craniocervical junction. And the whole idea is to try to predict which patterns of injury are going to predispose to instability. That's the key, because that is going to determine whether or not the patient needs to have an occipital cervical fusion or whether or not the patient can be treated conservatively with external bracing. So like we said, we have to have a good understanding of anatomy. So we're going to dive right into the anatomy here. So this is your craniocervical junction. So craniocervical junction is a little bit of bone and a lot of ligaments. And you have to have a good idea of where all these ligaments are located. So I'm just going to start anterior, and we're going to work our way posteriorly. So anteriorly, we have the anterior Atlanto-Occipital membrane complex, which consists of this portion, which is the Atlanto-Occipital membrane, and then this little portion down here, which is the Atlanto-Axial membrane. And it's called a membrane, but it's really just a fancy word for ligament. And then this ligament continues inferiorly in the subaxial spine, so inferior to C2, as the anterior longitudinal ligament. This is most likely a minor stabilizing ligament of the craniocervical junction. And it probably gives some degree of resistance when you hyperextend at the craniocervical junction. Posterior to that, you have the apical ligament, which runs from the basion of the clivus to the tip of the dens. The apical ligament, they've actually done cadaveric studies of this ligament, and this ligament is actually a notochordal remnant that exists between C0 and C1, and actually contains a little bit of notochordal tissue within the middle of it. And again, this is a minor stabilizing ligament, but it is a ligament you see on MRI, so it's important to know it exists. As we move even more posterior to that, we have the tectorial membrane. The tectorial membrane is a flat, broad ligament, which inserts actually really high up along the dorsum sella and retroclival periosteum. And it comes down and forms a kind of sling posterior to the C2 dens and continues inferiorly as a posterior longitudinal ligament. Now, the tectorial membrane, this broad, thin ligament, is actually one of the major stabilizing ligaments of the craniocervical junction, as we'll see. The transverse atlantal ligament, I'm going to wait and talk about on the axial images because it's a little bit hard to see on the sagittal here. And then as we move even more posteriorly, we get in the posterior atlanto-occipital membrane, which consists of, again, an atlanto-occipital membrane, which runs from the occiput down to the C1 posterior arch, and the atlanto-axial membrane, which goes from the C1 arch to the C2 arch posteriorly. So this forms a complex. It's kind of an analogous to the anterior atlanto-occipital membrane complex. And then as you get even more more posteriorly, excuse me, you get into the nuchal ligaments of the cervical spine, which we're not going to talk about. If you looked at these ligaments on a coronal, again, so this is the position of the tectorial membrane, again, and inserts on the high up on the clival dura, and then continues as a sling, and then continues as a posterior longitudinal ligament posterior to C2. If you cut that ligament away and looked a little bit deeper, you'd run into this ligament. And this ligament is actually called the cruciate ligament because it forms a cross. It has little superior longitudinal fibers and inferior longitudinal fibers that you don't generally see on MRI very well. But the part of it that's important is this part. This is called the transverse atlantal ligament. So it's part of the cruciate ligament. And this is a major stabilizing ligament of the atlanto-axial joint, as we'll see in a little bit. So it's important to know that. And then if we looked at a coronal posterior image, this would be the position of your posterior atlanto-occipital membrane and posterior atlanto-axial membrane. So atlanto-occipital membrane, atlanto-axial membrane, and this forms the posterior complex. So this is this transverse atlantal ligament seen in axial. So it attaches from one medial tubercle C1 to the other side. And this actually has a dual function. So this helps lock the dens in close apposition to the C1 anterior arch. So it prevents anterior translation of C1 on C2. But because there's a synovial joint capsule between this ligament and the dens, it actually helps facilitate rotation of the atlas on the axis as well. A lot of people refer to this as the most important ligament in the body. It's a very strong ligament, and it's one of the major, if not the only major stabilizing ligament of the atlanto-axial joint. So it is an important ligament to be aware of. So just again, biomechanically, so the major stabilizing ligaments, again, is going to be first the joint. So the bone-on-bone articulation between the condyle and C1, which we'll see in a little bit, and then the surrounding capsular ligament. Your alar ligaments. So we go back and look at the coronal image here. So you have alar ligaments, which attach from the occipital condyle and come down and insert on the tip of the dens on both sides. So it's these alar ligaments in combination with the tectorial membrane, which form a lot of the strength and biomechanical stability between the occiput and the C1-2 vertebrae. So alar ligaments, tectorial membrane, and then like we just talked about, transverse atlantal ligament, C1-2. And all those other ligaments I talked about, you can see them a lot of times on MRI, so it's important to know they exist, but these are really the minor stabilizing ligaments of the craniocervical junction. Okay, so we have some idea of the anatomy. So we're first going to look at the craniocervical junction in terms of its CT appearance. So obviously this is a CT scan here. So this is the important normal appearance of the craniocervical junction in terms of the bone relationship and the joint relationship. So the red arrows are denoting the atlanto-occipital joints on both sides. And the classic normal line is that the atlanto-occipital joint should measure less than 2 millimeters. The white line here is measuring the lateral atlanto-dens interval. So it's the space between the dens and the lateral mass of C1. And in a patient who's not rotating their head, these are generally going to be congruent and about the same distance. You have the lateral atlanto-axial joint spaces between the lateral mass of C1 and C2 body on both sides. And then the blue arrows are showing the lateral mass offset. So now why am I talking about all these relationships? Well, the reason is that you have to have a good idea of what is the normal imaging appearance of these different joint spaces before you can diagnose on CT an abnormality. So it's important to know what is normal. So again, just to harp on, so this atlanto-occipital joint, again, the C1 is the atlas, the occipital condyle forms this joint space. This joint space should normally be less than 2 millimeters in individuals, normal individuals. So what's confusing is when you first start learning radiology is that there's all these different relationships that you're supposed to measure to determine whether or not the craniocervical junction is normal. There's the anterior ADI, the Bayesian-Dens interval, the Wackham line, the posterior axial line, Powers ratio. Now, these are developed like 30 or 40 years ago based on plain film. And a lot of these, I would say most of these are unreliable. If you use the cutoffs that have been established in the literature to determine whether or not you have a normal craniocervical junction or not, you're going to be wrong a lot of the time. That being said, there is one in particular that you should pay attention to, and that is the anterior Atlanto-Dens interval. And that is the space between the anterior arch of C1 here and the dens. Now, a lot of times this can be abnormally widened in non-trauma patients, but it's a good relationship between the atlas and axis to be familiar with, and should be in adults less than 3 millimeters. So again, a lot of these lines are a plain film hangover. They're not sensitive or specific for a craniocervical junction spectrum injury. They can be abnormal in non-trauma patients. Patients who have cranial settling can have an abnormality in these lines. Patients who have rheumatoid arthritis, as an example, one of those craniocervical settling types, can have all these lines be abnormal. And then they can be normal, actually, in patients who have really significant trauma on their MRI. So not the best. So we're going to try to debunk some of that. We're going to talk about some other ways to determine craniocervical junction trauma on imaging. So besides the joint space relationship, the other CT findings you have to look for is whether or not you have avulsion fractures. So you can avulse the medial tubercle of C1, which is where the transverse atlantal ligament inserts. So if you have a fracture that pulls off the bone here, you know that you've avulsed your transverse atlantal ligament. Analogous here is the alar ligament insertion. So you can have a medial fracture of the occipital condyle in which the alar ligament has pulled off that piece of bone. Now you're going to see that on CT, and you're going to know that there's been an avulsion injury of the alar ligament because there's a certain type of fracture, either occipital condyle showing you the alar ligament being injured, or the medial tubercle showing you the transverse atlantal ligaments being injured. So besides joint spaces, avulsion bony fractures are the other thing to look for. And just as a few examples, so this is an example of a C1 ring fracture. And it's a specific type of fracture because we have an avulsion here of the medial tubercle. So the medial tubercle has been pulled off the bone here. So you know that the transverse atlantal ligament has to be incomplete as it moves from one tubercle to the other because you have this type of fracture. And then the other example is this occipital condyle avulsion fracture. So again, this is where the alar ligament inserts. And as the alar ligament gets torn, it can pull off a piece of bone. So if you see these kind of fractures on CT, you know that the underlying ligament is not intact. We did a little bit of research on condylar avulsion fractures of the condyle, and there's a lot of debate of whether these are stable or unstable injuries. And patients who have an isolated fracture of the occipital condyle and without any other joint space widening or fractures, those are typically going to be stable injuries and are treated conservatively with external bracing. So it's an important point to know. Okay, and then the third thing you can look for on CT exam is if you look on a specific kind of windowing, a soft tissue windowing, you can look for a hematoma or an effusion in certain locations. And careful evaluation of cervical spine CT is, you need to use a soft tissue window. So you use the bone window to look for the fracture, use a soft tissue window to determine where there is a hematoma. So this is critical. There are certain locations that you need to look for hematoma on CT. There's the supradental space, which is the space going to be right superior to the C2 dens. There's the retroclival epidural space. There's the prevertebral space and the dorsal epidural space. And we're going to look at all of those. So the first one we're going to talk about is the supradental space. So again, this is a normal supradental space. This is your apical ligament. In the supradental space, normally there's fat and there's a venous plexus. And sometimes you can see the apical ligament going through this. So this is what it should look like on CT and MRI. You have a little fat pad here on CT, which is the dark area. And then this is a T1 and a T2 weighted MRI, and it's bright signal because there's fat within it. And then you can see a nice little apical ligament there. So that's what it should look like. Now, we looked at this space specifically in patients who had tectorial membrane injuries. And what we found was that patients who have a tectorial membrane tear, which is the ligament that goes right posterior to this space, they get hematomas in this space. And you can see that that little fat pad that we just saw now is gone. And that when we look at the T1 and T2 weighted imaging, there's no clean fat. Now that fat is gone on the T1, and it looks indistinct on T2, and then the patient has this tectorial membrane injury here. And then, of course, has a lot of other craniocervical junction ligaments too. So on CT, a hematoma is a nice clue in this compartment that there's something going on with the craniocervical junction, and the patient needs to have a follow-up MRI. And this is just another example. So this is a hematoma in the supradental space on CT scan. Again, catches your attention. You're worried that there's an internal derangement here, the craniocervical junction ligaments, and lo and behold, again, the tectorial membrane is ruptured, and they've got a tear as well, the anterior Atlanto-Occipital membrane complex. So this is a nice clue to look for on CT exams. Just as one caveat to that, the supradental space. So normally on a stir, so this is a sagittal stir, and it's a stir because the fat is suppressed. You can have bright signal in here. And why? Well, there's veins. There is veins in the supradental space. There's a small little venous plexus, and the veins are going to be bright on a stir, just like they are back here. This is normal. So the key is to not mistake this for an apical ligament tear. It's just a normal supradental space. Okay, another place to look for a hematoma is the retroclival epidural space. So the retroclival epidural space is a space between the clivus and the tectorial membrane. So if you remember what we just talked about, the tectorial membrane actually inserts and interdigitates with the retroclival dura. So this gets stripped off the bone. You get an epidural hematoma within the retroclival space. So this is what it should normally look like. This is when the tectorial membrane gets stripped off, and it gives you a retroclival, this is the clivus, epidural hematoma. And we looked at this, and what we saw was that patients who have this retroclival epidural hematoma is very commonly seen in kids with craniocervical junction tears, and specifically a tectorial membrane tear. So in adults, the tectorial membrane tear is you get a supradental hematoma. In kids, you get a retroclival epidural hematoma. And the reason is that in kids, the ligaments are more lax. There's actually, histologically, the ligament consists of a different degree of flexibility. So instead of rupturing the ligament, it tends to peel off the retroclival dura. So the CT appearance here is this abnormality where there's a retroclival epidural space hematoma. And then you see that on CT, and you're like, oh shoot, that's another clue that there's some kind of craniocervical junction ligament tear. And when you do the MRI, it shows that the tectorial membrane, which is the black line here, is no longer here. It's been stripped off, and then it developed a hematoma here. So again, using the CT as a clue that there's a tectorial membrane injury in kids. This is another example we saw of a retroclival epidural hematoma that we saw on CT scan. And then when you look at the MRI, the tectorial membrane here, which is this dark line, has been stripped off the bone. And they've developed this epidural hematoma in the retroclival space, posterior to the clivus. Now, there's other places to look for hematomas on CT scan, a prevertebral hematoma. So remember that you have the anterior Atlanto-Occipital membrane complex, which is the occipital membrane and Atlanto-axial membrane between the clivus and anterior arch of C1, and then from the anterior arch of C1 down to the anterior longitudinal ligament. And here it is on an MRI, the anterior Atlanto-Occipital membrane complex. So what happens is if you have a effusion or hematoma in this location that extends all the way to the clivus, it's again another clue on CT that there is some kind of underlying internal derangement of the ligaments on MRI. So we see this on CT, patients intubated here, we're like, this is not normal, this is suspicious for internal derangement. Specifically, what you see with a hematoma or effusion in this location is tears of the anterior Atlanto-Occipital membrane complex. So this is the anterior Atlanto-Occipital membrane. It's been kind of emaciated and partially ruptured here. And then when we look on the stir, it kind of looks like it's almost incomplete. So we use the CT scan, and this soft tissue abnormality to determine, you know, this patient needs a follow-up MRI, and they have a tear of the anterior Atlanto-Occipital membrane complex. And this was another example, the soft tissue fullness here at the C12 level. And again, we look at this, we're like, oh no, that's not normal. The patient needs an MRI to look at the ligaments here. And they have an anterior Atlanto-Occipital membrane complex tear again. Both the Atlanto-Occipital membrane and Atlanto-axial membrane is torn in this patient. So up here and down here. All right, so the last place to look for a hematoma on CT scan is the dorsal epidural space at C12. So we're doing the CT scan. Again, the patient's intubated, they're in a car accident, and we see this abnormality here. The red star is denoting that there's this dorsal epidural effusion that's occurring at the C12 level. We look at that, and we're like, well, again, that's not normal. That should not be there. That's suspicious for ligament tear. And this specific kind of finding on CT is associated with these stripping injuries of the posterior Atlanto-Occipital membrane. So the posterior Atlanto-Occipital membrane, if you remember, should be attaching here on the posterior C1 arch. It's been stripped off. And they developed a dorsal epidural hematoma at C12. And you can see that this low density collection on CT, again, is abnormal. It's this dorsal epidural hematoma or effusion. And then on MRI, it's right here. And then the posterior Atlanto-Occipital membrane complex has been stripped off. So just to summarize, so the CT, we're looking at joint spaces. We're looking at avulsion injuries, avulsion fractures, and then we're looking at hematomas or effusions in one of these 4 compartments. So those are all things you look for on CT to determine craniocervical junction injuries. And we actually ended up publishing this posterior Atlanto-Occipital membrane complex as well. So it's kind of a well-established. We had several patients with this kind of injury. Okay, so that was the CT evaluation. So now, the CT is done in the trauma setting, and then the patient, determined by whether or not the CT is abnormal or not, or there's a high clinical suspicion of spine trauma, they will then potentially go get an MRI. The advantage of doing an MRI is it allows you to look at all these ligaments directly and determine whether or not they're intact. So we have to know the radiologic anatomy of the craniocervical junction on MRI. And it's basically the same as that cartoon diagram we already showed. So this is showing you the position of the anterior Atlanto-Occipital membrane. Then that continues down as the anterior Atlanto-axial membrane. That's the normal appearance. Here is our nice little apical ligament within our supradental space. On this patient, you can actually see the little superior band, superior longitudinal fibers of that cruciform ligament. Posterior to that, we have our tectorial membrane, which inserts up here and comes down and forms a sling posterior to C2. And then if we move off kind of parasagittal, you actually get a nice look at the alar ligaments, which are coming from the tip of the dens and inserting on your occipital condyle, which is right here. And this red star is showing us the position of the longus capitis muscle. So this is the normal MRI appearance of ligaments. So let's talk about one more ligament here. So, and then on axial images, this is the normal appearance of your transverse atlantal ligament. So remember, that's that transverse band portion of the cruciform ligament, and that goes from one medial tubercle to the other. And this is the nice normal appearance, nice dark, thick appearance of the transverse atlantal ligament. So let's talk about, when is a ligament torn on MRI? How do you determine whether or not the ligament's intact or not? Well, you have to have 2 criteria. You have to have a focal discontinuity or disruption of the ligament, of that thin dark line on T2 weighted imaging. And then the second thing you need to see is increased T2 or stir signal in that ligament. So if you fulfill both of these criteria, the ligament's injured. Whether it's disrupted or not fully disrupted, it's definitely abnormal. So what does that mean in pictures? So this is, again, the intact transverse atlantal ligament in a normal patient. And this is what a transverse atlantal ligament looks like when it's torn. So you can see that that nice dark band that you see over here is absent on the right side. And then all the fibers are kind of been stripped off the medial tubercle, and there's increased T2 signal within the ligament. So that's an example of a ruptured transverse atlantal ligament. All right, so when we talk about these ligaments, we're going to take these kind of one at a time. So the first ligament I want to talk about is the tectorial membrane. So The tectorial membrane, again, is this thin, broad ligament, this dark line here, that forms a sling to the posterior to the C2 dens, and it's one of the major stabilizing ligaments of the craniocervical junction. If the tectorial membrane is ruptured in a patient, there is actually a high likelihood that patient's going to have craniocervical instability that's going to require surgery. So this tectorial membrane is an important ligament to recognize and know the different types of traumatic imaging appearance. And we looked at this, and there was 4 types of tectorial membrane tears that we observed in pediatric and adults. So we already looked at the first one. So in pediatric patients, they get these stripping injuries where the tectorial membrane strips off the retroclival dura, and you have a retroclival epidural hematoma. In adults, like we talked about, the tectorial membrane is more prone to rupture, out and out rupture. And the rupture can be at the basion level, the rupture can be at the dens level. Both of these are observed in adults. And then there's a 4th category in which the tectorial membrane is thinned out, it's stretched out, and it has this thin appearance where it doesn't have the normal thickness of the tectorial membrane in a normal patient. So we divided these into 4 different types. So like we already saw, this is what we consider the type 1 tear. So when the tectorial membrane is stripped off the clivus in a pediatric patient, that's a type 1 injury. And you can see that that's associated with a retroclival epidural hematoma on CT and MRI. This is the appearance in adults. So again, that thin black line is no longer there, it's absent, and there's increased T2 signal on the MRI. So that's consistent with a tectorial membrane tear. And you can have tears that occur near the basion of the clivus. This is the basion, so a tear at this level, or you can have these tears down lower of the tectorial membrane. And then again, that dark line is interrupted, there's increased T2 signal within the ligament. So that's also an example of a tectorial membrane tear. So it can have these different looks because it's such a long ligament. And then this is an example of that kind of thinned out ligament that we saw, what we called a type 3 injury, a type 3 tear, is that the ligament doesn't have the normal thickened appearance. It does up here, you could argue, but as you come down here, it tapers this weird look. And then this was a more subtle case in which the ligament looked a little thinned out more superiorly. So that is kind of that stretched out or probably partially torn tectorial membrane where some of the fibers have been stripped out. Okay, and then another ligament we can talk about here is the anterior Atlanto-Occipital membrane complex, which we already discussed a little bit in the study of a prevertebral hematoma. So again, the Atlanto-Occipital component, the Atlanto-axial component, and then it continues as the anterior longitudinal ligament when you get inferior to the C2 level. So again, an example of a anterior Atlanto-occipital membrane tear, the ligament is disrupted, there's increased T2 signal within it. Again, you can see that on both. This is a T2 weighted image, this is the STIR image, and then it's associated with these prevertebral hematomas. And if you are eagle eyes, you'll also see that this patient has a retroclival epidural hematoma and their tectorial membrane is stripped off as well. So a lot of times when you see one ligament torn in the craniocervical junction, you're going to have another ligament torn. And the more ligaments that you tear, especially those major ones, the more likely the patient's going to have occipital cervical fusion. So this is another example. So a little bit of soft tissue fullness at C12 in the prevertebral space. We look at the MRI. This is the T2. This is the STIR. And you can see that the anterior atlanto-axial component of that complex is torn just below the C1 arch. So this is the anterior C1 arch. This is the membrane. This is the membrane's discontinuous. There's increased T2 signal within it. And again, a prevertebral fusion associated with this kind of injury. Yet another example, so prevertebral effusion, you can see a little bit of soft tissue fullness on the CT, and then you have this disruption of both the anterior atlanto-occipital and anterior atlanto-axial membranes. So disruption of that thin dark line and increased T2 signal. Okay, so moving back, so we talked about the tectorial membrane, we talked about the anterior atlanto-occipital membrane. Let's talk a little bit about the posterior atlanto-occipital membrane. So anatomically, the posterior atlanto-occipital membrane complex is actually a pretty mysterious ligament. There's not a lot in the literature about it. What is in the literature is that cadaveric examinations have suggested that the muscle actually forms from the fascial covering of the rectus posterior minor muscle. and also off the vascular sheaths that surround the vertebral arteries. And it kind of congregates and forms this ligamentous complex that then inserts on the dura directly, the posterior dura at C1-2. So it forms kind of this myoligamentous dural bridge. So this ligament's been studied actually in the setting of cervicogenic headache a little bit, but we're going to talk about it more in the setting of traumatic injury. So again, so this is the posterior atlanto-occipital membrane component. Between C1 and C2, it's the posterior atlanto-axial component, and together it forms the posterior atlanto-occipital complex. So we looked at the different kinds of injuries that can occur in MRI in this ligament, and there are various types of MRI appearances. So this is what we designate as a type 1 tear. So a type 1 tear is when the ligament just has increased signal within it on the T2 or stir-weighted sequence. As you can see, this is the posterior atlanto-occipital membrane and atlanto-axial membrane both have increased signal. You know, as one caveat to this can be seen in the setting of a primary ligamentous tear, but this can also actually be a sign of a C1, C2 fracture as well. Sometimes you get referred edema in this compartment in the setting of a C1-2 fracture. So it's important to know that as well. So a type 2 tear is what we designated as a tear that has signal not only in both the atlanto-occipital and atlanto-axial complexes, but also within the rectus posterior minor and major muscles and nuchal ligament complex posterior to that. So you can see the difference between the type 1 and the type 2, that the increased stir signal is much more extensive here with a type 2 injury. Now, as the ligamentous tears get more significant and the force gets worse, you start to get these other kinds of posterior membrane complex injuries. This is the type 3 tear. So this is the one that we saw in the setting of a C1-2 dorsal epidural hematoma, where the membrane actually gets stripped off the posterior C1 arch, and you get this space that fills with fluid. And then you get this little thin line that we see here, which is probably a little remnant of the atlanto-axial membrane that's still attached in the posterior dura here. So we designated that as a type 3 injury. And then a type 4 injury is kind of the most catastrophic one. That's generally when you have through and through disruption of the fibers. The posterior dura and the ligament are absent, and there's just fluid just everywhere. There's no black line coming down here. You can see we still have the dura intact here, this little atlanto-axial ligament. This one completely gone. So these type 3 and type 4 tears are much more likely going to be associated with other craniocervical junction ligament tears. You can see up here the tectorial membrane's torn, that there's, you know, gross disruption of the atlanto-occipital joints. So these tears are more of an indication of a high-grade injury. Okay, so what patterns of injury are going to lead to instability? So the important thing when I started doing research in this field is that in the absence of overt dislocation between the atlas, which is your C1 vertebrae, and the occiput, in the absence of that, there is no neurosurgical consensus on what patterns of injury predispose to instability that requires surgery. So there's a lot of things, there's a lot of radiologic research that we can contribute to help out the neurosurgeons and help study this process moving forward. And it's important to realize that you can have an occult craniocervical dissociated injury on cervical CT. Remember we talked about the joint space on CT between the atlas and condyles. Well, you can actually have a normal joint space and still have very significant injury. So a lot of neurosurgeons, from my experience, are going to look at a CT like this and they're going to be like, well, this isn't a craniocervical injury because this is the occipital condyle, it's the lateral mass C1, that's a normal joint space, it's 2 millimeters or less. And then this is the other side, and I mean, you could argue there's a little bit of asymmetry, but if you call this on people, you'd be wrong most of the time. When they look at this side and be like, all right, well, that side's normal too. So be like, all right, next patient, we don't need to do anything for this patient. And then because this patient was still having a lot of cervicogenic and craniocervical neck pain, they did an MRI and all the ligaments are torn. And this patient had to have surgery for occipital cervical fusion. Tectorial membrane's torn, the anterior complex is torn, the posterior complex is torn. And it's not shown here, but the alar ligaments were torn as well. So all your major craniocervical junction ligaments are torn, even though this joint space relationship is normal. So it's important to realize that you know, just because this is normal doesn't mean the patient does not have an injury on MRI. And this case was a little bit more obvious on CT, but not flagrantly obvious. So this is the normal Atlanto-Occipital joint on one side, less than 2 millimeters. This one, there's a little anterior subluxation. If you weren't careful, you may not see that, or you may kind of be like, all right, maybe that's just a little asymmetry, that's developmental. But, you know, instead of a high-speed MVA, you got to take this finding for what it is. And this patient, again, gets a cervical MRI. And then we got tears of their anterior complex, their tectorial membrane, the posterior complex. They had tears of their other ligament. And this is another patient that, even though the Atlanto-Occipital joint space is relatively normal, all the ligaments of the craniocervical junction are torn, and they ended up having surgery as well. Okay, so that was a ton of information. I hope I didn't go too fast. The take-home points I'd like you guys to know is that craniocervical junction trauma, it's a spectrum of varying injury to the bone and the ligaments, and it can or may not predispose to instability of the craniocervical junction. To begin understanding craniocervical spine trauma, you need to know your anatomy and understand which ligaments contribute which biomechanical role. So you have tears of tectorial membrane and other ligaments, that patient's not going to have stability at the craniocervical junction. They're going to need surgery. You have tears of the anterior and posterior complex, you know, that patient's probably going to do okay with external bracing. So it's important to have some biomechanical understanding. You really, really help out the neurosurgeons if they trust you, if you have this kind of understanding of the anatomy and the biomechanics. And then I want you to understand kind of the complementary role between CT and MRI in evaluating trauma of the craniocervical junction. CT, remember, relies on joint space abnormalities, so widening of the joint space. It relies on bony avulsions where those ligaments insert. And it relies on, if you look at soft tissue windows, the hematomas in specific locations that can be an indication of a ligament tear. Whereas MRI allows you to directly look at the ligaments and determine whether or not they're intact. So they're complementary imaging modalities. And a few references. So I appreciate your attention. Thank you very much, Health for the World, for having me. I hope you guys got something out of that lecture. And yeah, it was a pleasure. If you have any questions, you can look me up on Twitter or email me. I'm happy to talk with you. So thank you very much.
Thank you, Dr. Fiester, for such an excellent talk. I see there are some questions in the Q&A, and I just wanted to, before we start the question, I just wanted to kind of inform all our attendees that Dr. Fiester has done extensive research on this craniocervical junction topic, and we are very pleased to have him in our grand rounds to speak about this important topic. And I just wanted to highlight one of the questions which Dr. Enrique had put it in the chat. He had asked, do you recommend using CT or MRI to evaluate this pathology? I think by this pathology, he means when you were showing about the type 1 and type 2 tears. And if you could go back on the slide.
Yeah. So are you referring to the tectorial membrane tears?
He is. He's referring to the tectorial membrane tears when you were explaining about the type 1 and type 2.
Yeah, so, you know, at a trauma center, we're at a level 1 trauma center at University of Florida, and trauma centers around the country and in the US relies so heavily on CT as kind of an initial screening tool. So it's almost an automatic thing where the patient that has a bad trauma and the ER is going to get a cervical spine CT, no questions asked. And, you know, tectorial membrane tears you're not going to directly see them on a CT. But the idea is that you can indirectly infer that they are present if you see hematomas in certain spaces. So in kids, if the hematoma is posterior to the clivus, or in adults, if the hematoma is in the supradental space on the CT scan, it's suspicious for a tectorial membrane tear. And because it's suspicious, then as a radiologist, you should recommend a follow-up MRI to see if the tectorial membrane is torn or not. You can directly see it on MRI. So at our place, the CT will be done first, and then potentially the MRI will be done second. But really the imaging modalities, it's a complementary role between CT and MRI. So both are going to allow you to kind of evaluate to some extent the integrity of the tectorial membrane. But MRI is going to be the one that's going to allow you to determine specifically whether or not that ligament's intact. If that makes sense.
Yeah, I understand. Also, one of the questions on a similar topic was that how do we suspect PLCC injury on CT specifically?
Which type of injury? I'm sorry.
So it says PLCC, I'm guessing it's posterior complex.
Posterior. So in the majority of patients, a CT scan is not going to give you the information that the posterior ligamentous complex is torn, if I can find it. There's only one type of tear in which you can potentially call it on CT scan. This one. So these are the examples of the posterior membrane complex injury, the type 1, a type 2, a type 3, and a type 4. These two you can probably see on CT scan because the C12 epidural effusion here. So I don't have I can go back and look at it. But the degree of fluid in the C12 dorsal epidural space and degree of fluid and soft tissue swelling back here posteriorly is generally something you can see on CT scan. These types of injuries you're not going to see on CT scan. These will be ligamentous injuries that you're going to see on MRI. So if I go back and look at the posterior membrane complex tears on CT, so if you see this finding on CT scan in which you have this fluid posterior to the dura, you can be fairly certain that the posterior membrane complex has an injury in it. And then you do the follow-up MRI, and of course it confirms it. So there's only certain types of posterior membrane complex injuries in which you will see them on a CT scan. Whereas the lower grade ones, you're not going to necessarily see on a CT scan. You're going to need the MRI.
Yeah, that's an excellent point. Some of the participants from our countries also like heavily base like their imaging on CTs because that's more kind of common in resource limited settings. So it's like a good idea to have both like perspectives both on like how these tears and how these injuries look on both CT and MRI.
Yeah. And the scary part is the last thing I was talking about is that, you know, and I've seen this a couple times and I've talked to some neurosurgeons about this situation in which you have this as the CT finding and it's a normal joint space, but they have instability. And over time, this patient's not going to be managed with surgery. What's going to happen is that you're going to have this slow progressive anterior subluxation usually of the skull base on C1, and then you start to get cord compression. And then it becomes an emergency where the patient could potentially die. So, you know, the CT can undercall, the MRI can sometimes overcall. So it's kind of like all of medicine and definitely radiology. There's an art to this and there's an experience factor that plays in. So there's no right way to do it, but, you know, we can do our best with the imaging we have available and kind of go from there.
Yeah, absolutely. This is like such a subtle finding. And if we kind of miss it on CT, then it's going to be very hard to kind of put the dots together. Do you recommend, for example, for this particular finding, if there are any clinical findings which kind of alert the physician that, okay, this patient needs to undergo an MRI to kind of, you know, suspecting that this might be an occult injury?
Yeah, so luckily in a patient like this, if you relied only on the bony relationship here, you would miss this injury. But if you rely on that hematoma fusion point that I was trying to discuss here, is that this is going to show up on a CT scan, the soft tissue thickening here. So the degree of underlying injury is not going to show up on the CT scan, but if you can find the subtle clues like a prevertebral effusion or a supradental hematoma, those are the clues that you can sometimes see on CT, in which the radiologist can then be like, hey, this patient needs to get a cervical MRI. I'm still suspicious there's significant injury here. So that's the goal, is to try to use the soft tissue windows on the CT to help guide you into what patients, even if they have normal joint spaces, what patients may still have underlying ligament injuries on MRI. So it can be very difficult though, for sure.
Yeah. That's an excellent point. Also, someone wants to see the slide references because of all the extensive research you've done and kind of read through it. If you could show the slide.
Sure, it's not an exhaustive list, but if you if you look up my name of PubMed, you'll see the complete list. But this is just some of the research that we've done. So yeah, it's a, you know, I got into this because, you know, I knew there was a need in the neurosurgical community, and I've, you know, formed good relationships with neurosurgeons, and, you know, it really, they've got a hard job with these injuries because trying to determine which ones need surgery and which ones don't is pretty, it can be very difficult. And having a fusion, you know, the treatment is pretty straightforward from my understanding, but having the treatment, which is an occipital cervical fusion, basically fuses your skull to your spine, in which you are no longer going to really be able to rotate your head in a normal way. So the quality of life you're giving someone who undergoes occipital cervical fusion is not great. So you don't want to give someone this surgery if they don't need it, and vice versa. You don't want to ignore someone who needs the fusion. So, you know, the whole idea is trying to pin down which patterns of injury are going to need surgery and which patterns of injury are going to need potentially just, you know, conservative therapy. So that's kind of the take home point.
Absolutely, because as a radiologist, especially like these days, it's all the diagnosis as well as surgical planning management is so heavily dependent on imaging and the opinion of a radiologist. It's good to know all these subtle findings and alert the surgeon accordingly, and, you know, do what's best for the patient.
Yeah, absolutely, definitely.
So I don't see that we have any more questions, but if we do not have, we can just wait for a couple more minutes since we have time till 11. Maybe if somebody wants to add any questions, feel free to add it in the Q&A box or in the chat box, and we can ask Dr. Fiester. By the time we are waiting, I just wanted to comment how excellent the case images were, and, you know, how you had highlighted each image with arrows, and like you had at the same time you had put the anatomy image to kind of, you know, correlate both of them. It's very important because the MRI of the spine, especially the ligaments, could be like so confusing.
Yeah, it's confusing to most radiologists who are done with training. So it's, like I said, it's kind of it's a little bit of a ignored area of the body, which is to me kind of baffling because it's so crucially important for survival to have those ligaments intact. So, you know, I think a lot of the x-ray research that was done on this like 20, 30, 40 years ago relied on Atlanto-Occipital joint space widening. Basically just looked at the joint space, looked at the Bayesian-Dens interval and all these lines that are not reliable. And we've proven they're not reliable because now we have CT and MRI, which can directly look at all this stuff. So unless there's really overt decapitation, for lack of a better term, on the imaging studies, a lot of these injuries are going to go overlooked. So, which is not good. So yeah, spread the word, and you guys will be the new generation. A lot of you are in training, the new generation of radiologists, you know, to have a more subtle, you know, and deeper understanding of this. You know, that's the goal.
Absolutely. I think most of our attendees are very grateful for your talk. We have people from Mexico, we have people from Ghana, and everyone is really appreciative of how the imaging findings of such an important topic looks on imaging, because like I have practiced somewhat in India a little bit. Like I did 1 year of training and we had so many trauma, and then like the imaging was so heavily based on radiograph, like just plain radiographs and CT rather than MR. And it's good to know like what are the indications of MRI and how the MRI findings look on for this craniocervical junction abnormality. So someone has asked, will the slides be available? So I just want to say that, yeah, the talk would be is recorded and it will be put on the website, and you're free to use that. Yeah, I don't see any more questions, so we can adjourn. I just wanted to say that I'm so pleased to have you with us on our grand rounds, and it's I'm very grateful that all of us could learn about, say, craniocervical junction abnormality from you.
Yeah, and thank you for having me. I appreciate it.
Thank you, Dr. Feaster. Thank you, everyone, for joining.
Yeah, thank you. Take care.